Today's topic in EKGs is the Wolff-Parkinson-White syndrome, also known among cardiologists as preexcitation. Learning objectives: to be able to define preexcitation and to describe its various forms, to differentiate the Wolff-Parkinson-White or WPW pattern from WPW syndrome, to identify the approximate location of an accessory pathway in WPW, and to describe the mechanism and EKG characteristics of arrhythmias caused by preexcitation. Preexcitation is the propagation of a depolarization wavefront that occurs more quickly than normal due to the presence of an accessory conductive pathway that bypasses the normal conduction system. Here's a schematic of the normal conduction system. We see the SA node, the poorly defined intranodal tracts, the AV node, His bundle, bonal branches, and Purkinje fibers. And there's an impulse moving through the conduction system normally, with a brief delay occurring at the AV node. This animation is obviously very slowed down. Now, here is the conduction system inside the heart. You can see that the right and left atria get depolarized as soon as the sinus node fires, which in a real beating heart would lead to atrial contraction. Then after AV delay, there is ventricular depolarization, which utilizes the efficient and quickly conducting His-Purkinje system. The consequences of this on the EKG are a P wave with a PR interval of 120 to 200 milliseconds, followed by a brief and sharp QRS complex lasting less than 120 milliseconds. But let's add in an abnormal accessory pathway, one that bypasses the AV node and which has no intrinsic delay. We see that part of the ventricular myocardium is now depolarized early. This results in a short PR interval. In addition, because this accessory pathway usually, but not always, inserts into non-specialized myocardium, instead of directly into the His-Purkinje system, propagation of this aberrant conduction, once it gets to the ventricles, is relatively slow. This slow intraventricular conduction results in a wide QRS complex. The QRS complex has a specific characteristic addition, an initial slurring of the complex, usually well defined, which is the primary cause of the QRS prolongation. This slurring is called the delta wave. Most textbook-provided examples of delta waves are like this one, in which the delta waves are positive deflections before predominantly positive QRS complexes. However, they can also be initial negative deflections, which can be mistaken for pathologic Q waves from a myocardial infarction. So in summary, we have three classic EKG features of preexcitation: a short PR interval, a delta wave, and a prolonged QRS interval. A lot of introductory EKG textbooks refer to this accessory pathway leading to preexcitation as, quote, the bundle of Kent. I recommend against using this terminology for three reasons. First, while Kent did describe unusual conduction system pathology, he apparently never described accessory pathways explicitly. Second, by referring to it as the bundle of Kent, it implies that there is one specific pathway that patients can potentially have, while in reality there are many different variations. Finally, electrophysiologists themselves generally don't use the term. So if we don't call these pathways the bundle of Kent, how should we refer to them? Well, it's best to simply label them based upon anatomy. So in the example we showed a minute ago, we had a right lateral atrioventricular pathway. Atrioventricular pathways are the most common. Accessory pathways can also be atriofascicular, nodal-fascicular, nodoventricular, and vesiculoventricular. These are collectively but inconsistently referred to as Maheim or Maheim-like fibers. They can also rarely be atrionodal, in which the pathway joins the atria to the AV node at a point distal to where the AV node delay occurs, which results in a short PR interval but with a normal QRS complex. These pathways are uncommonly called James fibers, which can lead to an uncommonly used eponym Lown-Ganong-Levine preexcitation. They can also rarely be atriohisian, which have been labeled Breckenmacher fibers. However, as with the bundle of Kent, I do not recommend using any of those eponyms because of their imprecise and inconsistent usage. Instead, just refer to the pathways by their specific anatomy. And whenever someone refers to a, quote, accessory pathway, it's assumed to be the atrioventricular type unless otherwise stated, since they are the most common and most clinically relevant. Accessory pathways are remnants of the connections between atria and ventricles, which are present during embryological development. They remain behind following birth when there is a failure to achieve full fibrous separation between the atria and ventricles. They can occur anywhere within the AV groove, adjacent to the fibrous rings of the heart, which surround the tricuspid and mitral orifices. If we see delta waves present on the EKG, we can hypothesize the location of the pathway based upon the polarity of those delta waves in different leads. We can't know for certain without doing an EP study, but the study will be more efficient if we have a good idea from the EKG where to start our search for the pathway. Localizing accessory pathways is rarely something that a non-electrophysiologist will need to do, and thus this may be more detailed than some viewers are interested in. If so, you may want to skip ahead about 5 minutes to the point where I start talking about arrhythmias, which will be more relevant to a general audience. For those of you who are interested, localizing the pathway requires knowledge of the anatomical terminology of electrophysiologists. Here's a general schematic of the heart that we've seen several times in the video series already. Currently, we are interested in the tricuspid and mitral valve annuluses. One significant problem with almost all diagrams of the heart is that they make the tricuspid and mitral valves look far apart from one another, which is necessary when the heart is represented by a 2D illustration. However, as a three-dimensional structure, the tricuspid and mitral orifices are in close proximity to one another. Let's take a look at these orifices in isolation, and this somewhat disorienting vantage point is looking up at the tricuspid and mitral valves from the apex of the heart. We can divide this map in half. All pathways on the right side, in the vicinity of the tricuspid valve, are said to be right-sided pathways. Predictably, all those on the other are said to be left-sided pathways. From here, we just work our way around each orifice, dividing up the circle into different regions. We have anterior pathways, anterolateral, lateral, posterolateral, posterior, posteroseptal, coronary sinus, midseptal, and finally anteroseptal. With the exception of the midseptal and coronary sinus pathways, the remaining pathways are designated by both side and radial location. In addition, all of the regions that don't include the septum are sometimes collectively referred to as free wall pathways. Using this scheme, electrophysiologists will confirm the location of the pathway during an EP study prior to ablation. This process can be made more challenging by the fact that patients can have more than one accessory pathway, which happens much more frequently than by chance alone. For some reason, some patients were just particularly prone to developing multiple accessory pathways during embryological development. Another challenge to mapping is that accessory pathways show variable conduction at different times and in different situations. So the distribution and polarity of the delta waves on EKG is not necessarily consistent. There have been several algorithms developed over the decades to aid in the localization of accessory pathways from the EKG. I'll demonstrate one algorithm called the Arrhythmias approach after one of the cardiologists who developed it, but there is no specific reason to use one over another. It's very possible that a combination of approaches, when used by an experienced cardiologist, might be more accurate than any one approach by itself. The Arrhythmias approach focuses on the polarity of the delta wave in leads 1, 2, and AVF, and the R/S ratio in V1. The first step is to determine whether the pathway is in the left free wall. I'm not going to go through the algorithm line by line because that will be kind of painful to listen to, but instead let's work through two examples. So here's example 1. The first question, is the delta wave in lead 1 isoelectric or negative? It is, so we are dealing with a left free wall pathway. The next question, what is the polarity of the delta wave in AVF? Since it's positive, we have a left lateral or left anterolateral pathway. Here's a second example. Is either the delta wave in lead 1 equiphasic or negative, or is the R/S ratio of the QRS complex in V1 greater than 1? No on both counts, so we do not have a left free wall pathway in this case. Next question, is the delta wave in lead 2 negative? No, it's not. Is the delta wave in V1 isoelectric or negative? Yes, the delta wave in V1 is negative, so we have a septal pathway. Next, what's the polarity of the delta in AVF? The delta in AVF is negative, which makes this EKG a right posteroseptal pathway. So far in this lesson, I've been referring mostly to preexcitation rather than Wolff-Parkinson-White syndrome, which is probably the term more likely to be familiar to you. Let me explain the relation between the term WPW and preexcitation. The WPW pattern exists when an EKG has the features of preexcitation, but the patient is without symptoms. The WPW syndrome is when the EKG features of preexcitation are present in a patient with symptoms, which are presumed to be secondary to the related arrhythmias. These symptoms can potentially include palpitations, lightheadedness, syncope, chest pain, sudden cardiac arrest, and sudden cardiac death. The arrhythmias seen in WPW can be put into two categories. One category of arrhythmias are those only seen in WPW because they require the existence of an accessory pathway for their propagation. The other category of arrhythmias can be seen in patients both with or without accessory pathways. The existence of accessory pathways in the second category of arrhythmias can make them more difficult to diagnose or more dangerous to the patient. To better understand arrhythmias in WPW, let's take a look at a new, very basic conduction system schematic. Here's the SA node, the AV node, the His bundle, and right and left bundles. And here will be the accessory pathway. What does sinus rhythm look like in a patient with WPW? The sinus node fires, and impulses travel via the internodal tracts to the AV node, where conduction moves slowly before reaching the His bundle. Simultaneous to this process, the impulse travels from the atria down the accessory pathway to the ventricles. Now let's go back to those two categories of rhythms. The first category is seen only in WPW because they require an accessory pathway. The name for this collection of related rhythms is atrioventricular reentrant tachycardia, abbreviated AVRT. When the other category of arrhythmias occur in a patient with WPW, we can informally call those pre-excited non-AVRT tachycardias. There are two major subtypes of AVRT, both of which, as the acronym implies, are reentrant in mechanism. The first and more common subtype is called orthodromic AVRT. In orthodromic AVRT, a depolarization wavefront moves down the AV node and through the His-Purkinje system, and back up the accessory pathway to the atria, where the impulse finds the AV node recovered and ready to fire again, thus propagating the circuit. Each time the impulse reaches the atria again, depolarization moves back up through the atria towards the sinus node, which may result in P waves of retrograde or otherwise unusual morphology. The second type of AVRT is antidromic. In this situation, the impulse moves down the accessory pathway and backwards up the His-Purkinje system in AV node. P waves in antidromic AVRT are typically retrograde. Both forms of AVRT are typically triggered by premature beats. You may think that these two subtypes are quite similar, but they actually look very different on EKG. Let's look at some examples. Here is orthodromic AVRT. The impulse is moving down the AV node and His bundle and back up the accessory pathway. Since there is no forward impulse down the accessory pathway, there is no delta wave during the rhythm. The QRS complex is narrow and should be normal in the absence of other pathology. Since the accessory pathway may conduct retrograde more quickly than the AV node conducts forward, the P waves are typically found after the QRS complex and not beforehand. Another way to phrase this is that the patient has a short RP interval. And those P waves are of unusual morphology since they are originating from the proximal insertion site of the accessory pathway and not originating from the sinus node. Permanent junctional reciprocating tachycardia, or PJRT, is a particularly incessant subtype of orthodromic AVRT mediated by a concealed AV accessory pathway, usually within the posteroseptal region. The term concealed refers to the fact that the accessory pathway is only capable of conducting retrograde. PJRT most often presents in early childhood. It shares many similar electrocardiographic features as a conventional orthodromic AVRT, with the exception that the interval between the QRS complex and subsequent P wave is longer, that is, it has a relatively long RP interval. This is because the concealed, retrogradely conducting pathway in PJRT conducts relatively slowly compared to most other accessory pathways in patients with WPW. P waves in PJRT are retrograde, meaning they are negative in leads 2, 3, and AVF. And here is antidromic AVRT. It looks quite different from the orthodromic variety. First thing you probably noticed is that it is a regular, wide complex tachycardia. Since the ventricles are depolarized only from the accessory pathway, and not from the His-Purkinje system at all, the QRS complex during the rhythm is even wider than when the patient with WPW is in sinus rhythm. The P waves are often not visible, but if they are, they do not show AV dissociation, which would indicate the rhythm was actually VT. The directionality of QRS complexes in antidromic AVRT should be generally consistent with that of the delta waves while in sinus rhythm. What do I mean by that? Well, let's zoom in on this EKG and take a look at the QRS complex lead by lead alongside the patient's EKG while she is in sinus rhythm. Lead 1 is downgoing, and leads 2 and 3 are both upgoing, consistent with the delta waves in her baseline EKG. AVL is downgoing and AVF is upgoing, again consistent with the directionality of the baseline delta waves. V1 through V3 are upgoing. The prominent negative waveform in V3 is actually an inverted T wave. While the QRSs in V4 through V6 in the AVRT are a little more equiphasic, while the baseline deltas are a little bit more positive, this discrepancy is small enough that it could be due to small variations in electrode placement. Now, let's take a look at the pre-excited non-AVRT tachycardias. Keep in mind that since they are occurring in patients with WPW and delta waves, the tachycardias in these situations will all be wide complex. As sort of already mentioned, we have sinus tachycardia, which looks just like you would expect it to, like the patient's baseline EKG with short PR, delta waves, and wide QRS, but just at a faster rate. The patient could have atrial tachycardia, where there is an ectopic focus that is beating faster than the sinus node. AVNRT, in which there is a very small reentrant circuit within the AV node itself. Each time a retrograde P wave is fired backwards through the atria, it sends an impulse down the accessory pathway too. Atrial flutter, in which there is a macroscopic reentrant circuit within the atria. And last, atrial fibrillation, in which there are many depolarization wavefronts acting chaotically in the atria, with an impulse running down the accessory pathway whenever they find it to be no longer refractory. This is particularly dangerous when a patient's accessory pathway has a short recovery time, since it may result in an extremely fast ventricular response that can degenerate into ventricular fibrillation. One property of accessory pathways that make them prone to this phenomenon is the fact that some demonstrate something called non-decremental conduction, which means that they conduct just as well at fast rates as slow ones. Here's an example of atrial fibrillation in WPW. It has a very distinct appearance. There are very few things which will cause an irregularly irregular, wide complex tachycardia. There are two more phenomena related to WPW to discuss. First is something called concealed WPW, which I mentioned briefly when showing the example of permanent junctional reciprocating tachycardia. Accessory pathways are variably conductive at different times and in different situations. In a significant minority of patients with WPW, the accessory pathway is not capable of antegrade conduction, only retrograde conduction. As a consequence, there are no EKG signs of WPW while the patient is in sinus rhythm, such as a delta wave and short PR. However, the patient is still at risk of developing orthodromic AVRT. This situation is called concealed WPW, and it can be difficult or even impossible to diagnose from EKG, as the presence of the accessory pathway can only be demonstrated during an EP study. Finally, there are a tiny number of patients whose EKG demonstrates something between manifest WPW, in which there are always delta waves present, and concealed WPW, in which there are never delta waves present. These patients have intermittent preexcitation, in which some QRS complexes have delta waves and some do not. Consider this EKG. Most of the QRS complexes here are wide, with a delta wave. However, the first, third, and 13th beat of the EKG have nice, narrow-looking QRS complexes, preceded by a normal PR interval. A specific subtype of intermittent preexcitation can occur in which every other complex is preexcited, alternating with ones that are not. This highly unusual phenomenon is predictably called preexcitation alternans. That concludes this video on the Wolff-Parkinson-White syndrome and preexcitation.